a link between the aortic stenosis and some of those findings?
Yeah, I think this is a great question. In terms of the link between AS and cardiac amyloidosis, there is definitely a biological link. Actually, autopsy studies have shown, and even resection of valves have shown that actually there's amyloid deposition on the valve tissue leaflets itself. So in the turbulence itself of the valve, just the jet stream also precipitates the deposition of that. So now this field is going to explode because therapies for cardiac amyloidosis are just coming at the corner now. They just had new drugs approved for neuropathy-related cardiac amyloidosis, and they're testing that. So I think it might be considered a two-pronged approach. Should we treat the valve, and should we treat the myocardium? Should we wait for the valve to become severe to treat that? It's fascinating, but it's really not uncommon.
John, during your talk, about 1,000 lights was going off in my head over there, and because I do think I struggle with these patients all the time in the office about what to do, because, you know, they're elderly, their ventricles are thick, they have like no symptoms that you can get out of everything, their gradients are high, and we just wait. And is there a standardization of the methodology for cardiac MR such that I could send them to Warren Manning and say, look, do a cardiac MR, and if my number is above 8% fibrosis, we should think about doing this to stop this irreversible process. How close are we to, I'm ready to go back and order tomorrow. So how close are we to be able to implement this? Because I think it's phenomenal.
You know, I really appreciate, Jeff, your enthusiasm, and I would like to share that this is actually quantifiable. The sequence has been described since the mid-90s and really proven to be there. What I think it has to be recognized is that, you know, image quality is dependent on a scanner and how you play with the sequences, but we can do this on a reproducible manner, in a much better way that we can predict. Now, what is the threshold by which, you know, we will have this inflection point that would say, beyond here, you should intervene or not, we still don't know. I think this very first paper that just came out last week, as I mentioned, in Circulation, is quite important. By the time these patients get intervened on, a lot of them have fibrosis, almost 50% of them. And actually, the non-ischemic is twice more prevalent than the ischemic.
Wow. Wow.
So these patients don't have coronary disease, but already they have ventricular suffering. So
we should do a registry or something. Are you going to put together a multi-center registry?
Yes, I think that's something that we would need to discuss amongst, you know, many of the other vendors. I think this is an incredible opportunity. And the good thing, Jeff, is that the reproducibility of CMR is so good that we don't need 500 patients. Yeah. You know, it's reliable. So
yeah.
You know, it is interesting because, you know, what imaging is continuing to teach us. When I started doing aortic valve surgery, which when I went into practice in 1985, I looked at an echo and I looked at the patient, and that was all imaging we did. Maybe we could operate, you look okay, you know, come on in. And I look back at all the mistakes I know I've made because of inadequate knowledge. So we have a few minutes left. Any questions from the audience for the panel? Yeah, Onkar?
Just wanted to build up on the discussion we're having about low flow, low gradient, severe aortic stenosis patients. They don't do well at 2 years, irrespective of how we screen them. I think the screening of choice is a dobutamine stress echo. And you demonstrate that there is systolic reserve or there's absence of systolic reserve, and you still go on and do the TAVR if the valve area, you know, it remains the same and the gradients go up, but they do poorly at 2 years. So is MR the diagnostic modality of choice in screening them? And like Jeff said, is there a quantifiable interstitial myocardial fibrosis number beyond which we would say, you know what, this is a poor substrate, myocardial substrate, we should not offer them TAVR? And then I would extrapolate the same question to another confusing group, which is paradoxical low flow, low gradient severe AS, which is another conundrum. I mean, some groups have described that you shouldn't do anything at all. But we see a lot of these patients in our practice, so yeah. I wanted to pick your brains on what you think is the best screening modality. Thanks.
Yeah, that's a phenomenal question. So I can break it down in two boxes. One would be the low flow, low gradient with low EF, and the other one would be the preserved EF. So using, again, EF as the metric, all right? So the low flow, low gradient with low EF, there has been actually a lot of developments in that sense. I think, you know, recently we published the Topaz TAVI showing that the butamine stress echo, it's good, but the flow reserve or contractile reserve does not predict outcome and does not predict who is going to improve LVEF. So the message there is that don't stop. Even if you don't have flow reserve, the patients do better if they treat. Now, the mortality might be quite high because it's tons of fibrosis and the opportunity to learn there. Avoiding the topic that I talked about the first talk, the dichotomania, I don't think we have yet that threshold by which beyond here you should do or should not do it. For the paradoxical low flow, low gradient, I love that slide that Dr. Holmes had. It's a mixed bag. And concomitant valvular disease, it's very prevalent in these patients, AFib, pacemaker, desynchrony, and amyloid. I think the amyloid is the one that falls under the radar screen. A lot of these patients have low flow, low gradient because the ventricle is just doing that, right? So, and they don't have enough flow.
So Mike can maybe chime in as well, but in the core valve study, we did those patients in our pivotal IDE trial that augmented to dobutamine, right? Yeah. So we did those patients, and if you pounded their ventricles with 20 mics per kilo of dobutamine, you got their gradients over 40, and we said, okay, you've got contractile reserve, you're in. And then along with that, we did an expanded use registry where we included patients with low flow, low gradient, those who got dobutamine and didn't augment, and those that had ejection fractions. That was our normal ejection fractions. And who did the worst of all of those? The patients who augmented with dobutamine in our high-risk trial. Completely opposite of what. So we sort this out a million different ways. But the TOPAZ study, I thought, was finally we had some validation that when we use dobutamine, as Dr. Holmes used it earlier, to find pseudostenosis, find people whose gradients don't go up very much, their valve area goes up, they need CRT, they need something else. But we have been treating patients that don't augment with dobutamine when their gradients are 25 to 30 or so, and they look like they have an ejection fraction of 25%, and it doesn't get better with dobutamine because we're completely confused about the role of dobutamine in that patient. Mike, do you understand the data?
I think the role of dobutamine is changing a lot now. I mean, I used it surgically for other reasons. So, obviously we would start off by trying to rule out pseudo-aortic stenosis, but then when we decided they had real aortic stenosis, if you have low EF, low flow, severe AS, and it's really severe AS, and I operate on you, your mortality is higher than if you have high gradient. If you don't augment, your mortality is huge. It can be up to 30%. And so I used it to screen out people that I didn't want to operate on. That doesn't happen in TAVR because we don't hurt them as much. Right. The other group of patients that we've learned a lot about that I find interesting, because again, I look back over my career and I see all the mistakes that I've made because we didn't understand it the way we're starting to understand it now because we look at it so closely, was the little old lady with paradoxical low flow, low gradient, because about half the time they'd come to surgery and you would open them up and their valve really wasn't that bad. And they had about a big enough valve for a 19 millimeter valve, and you weren't going to make them any better. And they're the ones that came off on onotropes and got a balloon and just faded away and never got better. Right. Whereas these people also do very well with TAVR because the hemodynamics, which you're talking about, are so much better than the surgical hemodynamics, unless you do a stentless root or you do a valve enlargement or something like that.
But I think that's an important point for everybody, is that at least in the TAVR world, we don't seem to be hurting them. I mean, maybe they don't do as well as other subgroups, but sometimes they get a little bit better. You still struggle with diuretics and beta blockers and things, but we don't seem to be hurting them. And so this may be an issue of where's the futility point where you don't do anything, but I wouldn't want the message to be that, if you see any evidence of low flow, low gradient and any of this fibrosis, that we shouldn't do anything.
Yeah, I mean, the point is well taken because we're looking from one metric, which is mortality. For them might be quality of life for some improvement. I would argue that, a lot of these patients, particularly the amyloids, the personal experience is that they don't tolerate even mild PVL. Myoparvalvular leak. Right. It's a ventricle stiff, and so you're better off with valves that don't cause pacemaker or PVL. So that would be a prosthesis choice. I have a question for Mario, actually, on the prosthesis, the valve thickening. Some of the discussion that we had a few weeks ago about use of warfarin, and warfarin actually in some animal models and even in humans associated with vascular calcification and valve calcification. Is there a concern there? I mean, how would you consider that? Because it does not come, there is no free lunch. So I mean, yes, you might reduce the leaflet thickening, but you might be calcifying as well.
Yeah, I think if you do it long term, right, and that's the question, how long do we have to do it? I know that, established surgeons, I trained at Mayo, Dr. Schaff was always saying we should do anticoagulation for all prostheses once they are developed. I think they even don't do it. But if you do 3 or 6 months of warfarin after a TAVR, I think you will have a much lesser number of patients who have this thrombosis. And I don't think that you have to do it long-term in all of them. But we still have to investigate how many have a recurrence of it, right? And I bring this up again because I really am passionate about it. I think we just don't know about enough about phenotypes in these patients. We just implant valves, and retrospectively we try to figure it out. And I don't know why none of these valve companies is investigating it from a phenotypical standpoint. So, but I think long-term warfarin shouldn't be the goal in TAVR patients.
Well, you know, I know Hartzell liked to anticoagulate, but one of the reasons I quit doing it was I read the Mayo papers that said it didn't make any difference. And so, you know, it's kind of interesting. We're going to have to wrap it up. I just want one final comment. I think one of the takeaways here is one of the things we're all worried about is durability. And what do you tell patients about durability? And as Jeff pointed out, if you do Kaplan-Meiers, it assumes everybody lives for 10 years. And the average US and Canadian aortic valve series is about 68 and a half years old. The average 10-year survival is 60%. So 40% of the people that are 68 years old are dead at 10 years, so their competing events are out. If you look at the TAVR studies where they're 83, you know, it's not going to fall out. We're really going to have the low risk is probably going to be our first good opportunity to get this. What I tell people as a surgeon is that it seems to be tracking what we see in surgical valves so far. And if you're 80, you're good to go. So thank you very much for the session.